Yeah. So I'm going to talk about the PTAB. I think you guys last night had to talk about this, right? So quickly. So no conflict of interest for this presentation. So prepare the talk, I went on AI and say, what's PTAB, right? And he's supposed to give us an answer for everything. And at the end of the day, it's basically very quickly, right? Basically, we're right. I always say the internet AI is all garbage in, garbage out, or data in, data out, right? So basically, it's patients who failed endovascular surgical revascularization, so patients we go for PTAB. So patient selection, very, very important. So long FEMPAP disease, chronic total occlusion, long lesions. In my practice, because I'm biased, I just get referrals to this. It's usually mostly diffuse incision restenosis and a first failed surgical bypass, and of course, patients are older that don't want to have surgery. So these are the patients that I get. Right? So what's PTAB? Very simple. It's ablating a bypass percutaneously. I think the idea was started here in Phoenix, right? This idea of doing a PTAB, right? Started in Phoenix, and I know we lost the guy last year. Correct. So you create a FEMPAP bypass, and I call it very, very simple if you think of the concept, right? So when I prepare for PTAB, it's basically first is procedural planning. And usually just anatomy, either get an angio, CTA, you know where the occlusion, SFA, where the reconstruction is, right? Then the next thing is I always do a vein mapping. So when I get to the clinic, I do these two things right away. So the procedure itself, actually, for me, it's only threefold, right? Only threefold, right? I tell the fellow, one is to prepare. First is the access. So you get contralateral arterial access, marked as one, right? Then after that, all I have to do is create a fistula between the artery and the vein, then distally from vein back to the artery. So that's the concept. Then, of course, after that, you deploy the stent graft, and then that's it. So female 87, multiple intervention. We have to go through all of this. Multiple right leg. Then the last one was in 2023, and they couldn't get it. And she was symptomatic for about a year. Then they called me, so we can give it a try. So I referred actually for PTAB at the time. There was a commercial PTAB came in. So first thing, like I said, is do a baseline angiography. So like this patient, aortoiliac arteries are okay. Then you see the occluded vessel, and you can see it's stented from the ostium all the way to the pop, and it's totally occluded ISR. Like I said, it's on my patient base. And then good thing is you have good two-vessel runoff. And I know very well that if you look at the old data from EPTFA graph, is that if you have a 2 to 3 vessel runoff, then your long-term patency is in the high 80%. So the first thing we do is vascular access, and basically twofold. 1A is antegrade arterial, and typically I put in a crossover, an 8 French 45 cm sheet. Then the second thing is then you access from the leg, distally, right, in front of the veins, and typically I just put in a 4 French or a 5 French 45 cm sheet, and you put the sheet all the way up to the popliteal vein. So that's your distal, proximal is up in the common femoral artery. So patient selection, I think is very, very obvious, right? The CTOs, symptomatic, of course. Then the key thing is I have to have a vein that's more than 10 millimeter, right? Or a duplicate femoral vein. The last thing you want to do is a small vein, then you cause DVT and all the problem. Okay. Then you like to have at least 1 vessel runoff. And for me personally, I like to have at least 2 vessel runoff based on all data that EPTF grafts stay open if you have 2 or more vessel runoff. So the next thing is creation of AV fistula. And again, very simple. We have a device called the endocross, right? And basically the first thing you cross from the SFA to the femoral vein, right? And then after that, after you created it, you create a fistula again from the popliteal vein to the artery. And I would say this is the most challenging part. The distal AV fistula is the most, or the VA fistula is the most difficult in terms of this procedure, right? And this is what you see, right? There's a device, right? And there's a needle. And actually the needle's about 15 millimeter throw, right? That means you have a 15 millimeter size. And then you need 2 wires, one for railing in the device and then one for the re-entry, just like the device that we have in the market right now that's also unguided, okay? So creation of AV fistula. Proximally, this is very easy, right? So like I said, we get the venous access and you inject, right? And you can see that I injected and you see the proximal vein all the way to the top, right? And then the first thing we do is you put the snare up there in the common femoral vein, in the superficial femoral vein. Then the next thing we do is you have to create a fistula from the A to the V. This one is a totally occluded SFA, so all I did was just create a lumen in the occluded stent, balloon it. So we have an open proximal SFA now. Then all I have to do basically is put the device in. Now the device, when you use this, you have all those markers to say, am I pointing up, pointing to the side, pointing to the left. You don't worry about those things. In the proximal SFA, the femoral vein is so huge that even if they get it right, you always get it. It's not an issue, right? And all you have to do is basically put the artery on top of the vein. And all I do is basically the artery, then the snare. Then with that, you just basically deploy the needle. It goes all to the back. Then you snare it. Then after snaring, you just pull it down, right? Then after you pull it down, you create a fistula by ballooning across the AV graft, right? And this is sometimes when difficult, just get a non-compliant balloon and do it. Okay, so you're done with the proximal segment. And this is very, very fast. When you do this, in a couple of minutes, you're done with this. Now, this is the more difficult part of the fistula creation. It's basically the distal segment, right? And the IFU says you do the A and P, anterior, posterior, posterior to anterior, which I don't use, right? I've been using a different technique, so I'll show you. So the first thing I have to do, after you create the fistula from the A to the V, you just advance the wire all the way down. Remember, it's just a snare. So you can pull it out, and it comes off the popliteal vein, right? The PT vein. So you have a floss. So with that, you can advance the second device in very easily, all the way down to the popliteal segment. Then the technique that I use is a lateral. What I do is I put the all the way to the side, A and V side by side, because with that, you can see from this picture here, right? I throw the needle, boom. You see it very nice, you advance the wire, right? The problem is when I do an AP, I tell the company that if I do the AP view, I don't know if my needle went in or went through and through, right? If I go to the side, if I go through and through, all I do is just pull back a bit, then advance the wire, right? So it gives me more control of the wire. So I've been doing this lateral technique, and I think it's a lot easier than just balloon it. Then with that, that's it, right? Actually, the procedure is done by the time if you cross to the V, to the A, and then all you have to do. Then, sort of one thing that I do is remember, when we're doing all this, it's an 014 system. An 014 system have no support at all, right? No support. The floss is okay because you're flossed, but the one that goes into the A, you have no support. It's hard to push anything down. So I do what I call my mother and child technique, right? So instead of putting the 018 support, I put an 035, then advance an 018 inside it. And you can see from this, which I see this often, if you get the 035 in, it just stays on that AV fissure, what I call the trap, right? And it won't go in. But then if you have an 018 in, look at this, it will just fly in easily. Then when that flies in, all you have to do is just advance the 035 in, then change on 035 wire. So it saves you a lot of time, a lot of the steps that we're doing. Then with that, you advance the stent graft in, right? And then with that, you basically deploy it, and then you have a very, very good recreation of the SFA to the pop. Then like in this case, you have a 2-vessel runoff, no problem. Okay, good. So quickly, then at the end of the procedure, get a venogram. Yeah, sometimes I forget to do this and you curse yourself. But always get a venogram, just mainly to make sure that you have no issue for DVT in the future, right? So data-wise, I think you guys know all the data about this, right? Most of them were CTOs, were part of the study. And then the nice thing is prime patis is 68.1%, right? And it calls me into question because we know very well from the surgical colleague, if you do an EPTFE grafting, our long-term results are not that great, okay? So this has way to be seen, right? And then DVT is not an issue. And then, of course, for this, my surgical colleague, I always do this with one of my surgical colleague, and we always say that the best thing for this is I can do the procedure, the patient can go home actually on the same day, and instead of surgery, right? So to finish the talk, these are the questions that I ask, right? So pre-procedural, right? Do I do a DCB, DES, or scaffold at the edge of the stents, right? Because the issue for this is the stent edge. Restenosis, that's where it happens. Right now, I haven't been doing any of this, but something to think about. Then, of course, after the procedure is DAPT, P2Y12 monotherapy plus low-dose rivaroxaban or full-dose rivaroxaban, or what we do in the coronaries, we do triple therapy for 1 month, then go to dual therapy with low-dose rivaroxaban. Something we need to basically get an answer, right? Because my failures, a lot of these failures are twofold. Edge restenosis, which we just balloon and stent and do DCB. It's been working. Then, of course, also DVT. So right now, I've been giving NOAC, DOAC to all those patients. And I think that's it. So in summary, it's basically option for patients who can fail surgical revascularization, who are not candidates for surgical revascularization, basically. And thank you.
Hey, Nelson,
Yeah.
I have a quick question regarding the sizing of the veins, the femoral vein. I mean, do you do that with ultrasound?
Yeah.
I feel like the vein is tremendously variable in size depending on the hydration status of the patient. So how do you trust when it's really 10 or whether it's overfilled or underfilled? Or if I mean, I don't trust the whatever measurements you get for that.
I agree with you. And actually, I have a patient where I have a big vein, right? Then after 1 month, comes with a DVT.
Yes.
Then you say, why did I get a DVT? The vein is huge.
Yes.
Yeah, that's a problem.
So anyway, sorry.
Yeah.
And another
So
question.
that's why I said maybe DOAC, NOAC is a solution to the problem. I'm not saying that's a solution, but it could be the solution to the problem.
You have a question as well? Please.
DVT occurs because of the foreign body in a slow flow state. So as long as the vein has slow flow and you have such a long stent, it's bound to happen.
Renee, so the patient I had that developed DVT, I put him on NOAC, DOAC for about 3 months. Then I stop it, and they're quiet after that. So there must be some other things. Could be, yeah. Although the study showed a very low risk of DVT, about 2.6%. Yeah. Okay, good. I think Dr. Noah.
Excellent.